Hi, my name is Maddie Miller, and today, as the Week 5 final presentation for Communication and Health Disparities, I'm going to be presenting on the current state of and improving access to medical interpreters in Gwangju, South Korea. So before getting started, I wanted to talk about the reason I'm doing this and why me specifically. So I lived in Korea for quite some time, and I have an affiliation with most of the following associations or organizations that are related to migrant health and language interpretation. One of the first things that I wanted to talk about today was why interpreters? How are interpreters or access to interpreters a disparity? So one of the first things is about patient satisfaction. So Ngo and Metzger from 2007, they showed that interpreters are not as good as ethno-linguistic concordance between the patient and the provider, but given Gwangju's context, there's virtually no chance for patients to meet someone from their same country. And then also Diamond and Jacobs showed that interpretation, live interpretation, is better than the healthcare provider using their own foreign language competency, because often it just drives disparities deeper. It just widens the gap rather than helping facilitate equitable care. So also the interpretation, the presence of an interpreter in a health encounter improves health outcomes, and using interpreters is often more effective than other methods. This is speaking from my own research using interviews with 34 migrant families. And so the majority of them would prefer to have an interpreter than use something like AI, though a lot of them do end up depending on something like Google Translate to help them because there are no interpreters available. So I also wanted to talk about the current state of interpretation in Gwangju. Because of the low awareness of Korean healthcare providers about interpreters, there's typically a sense of dread when meeting migrant patients, assuming that they will make the encounter slower than it should be and kind of set them behind on their patient schedule for the day. Currently, 15.8% of migrants reported being unable to seek or receive medical care because of the inability to communicate in the language. And this could be they went to the hospital and were denied care or were not able to receive the care they wanted. Or this could be that there's some apprehension and so they perceive a language barrier and then don't proceed to seek care because of that uncertainty. Also, 36.8% of patients who end up actually seeking care say that language is a major difficulty during the encounter. And then personally, I can attest to the fact that it's very hard to find an interpreter. You can't, basically. Many people use their church or their personal social network, but that often means that they are not professional. They are just ad hoc interpreters, which obviously the quality of that interpretation is going to be reduced. Also, Che and Park in 2017 said that a convenient and credible interpretation service has not really been researched as a major resource for healthcare and migrant care. And so moving forward, seeing it as a vital factor in research is critical. Also, there is a huge overload on 2 university hospitals because they are the only places that employ full-time on-site language interpreters in English, Chinese, and Russian. So unfortunately, there are only those 3 languages available, and it's only these 2 hospitals. So there is a pretty strong sense within the migrant community that if you do need those language interpretation services, this is the place to go. So they're a bit swamped. There's not a much opportunity for care because of how busy it is there. So how are these things disparities? How does it relate to our class and the final presentation? Scheppers in 2006 talked about 3 levels of disparity. So the first one being patients. Patients are not aware. So this becomes a disparity because they don't know how to access interpretation services. On the second level of providers, providers often don't know how to use interpreters. What good are they? How do I use them maximally in the encounter? And then on the third level, for systems or organizations, there's very little training or credentialing of interpreters, meaning that they're not very available. There is essentially no infrastructure for them. And also, there's no real information about interpreters available online or in the media or from kind of government organizations or things like that. There's not really infrastructure for information. So then I'd like to talk about what is happening. What interpreter services do we have? So Gwangju Migrant Health Center has a few interpreters, almost all of them Vietnamese, and there's a little bit of a chicken and egg situation happening here because they have so many Vietnamese patients, they apply for interpreters, for funding from the government for interpreters. So then these interpreters are able to facilitate a better health encounter for them. They leave satisfied and they go tell their friends. So then because of more interpreters, we have more patients. But other nationalities don't have an interpreter currently, so they're not able to kind of facilitate this chicken and egg situation. Something needs to start the cycle. And this is effectively only a solution from the systems level. There's no information broadcast. They don't use social media. They don't have any like news about it online. Their website is very out of date. And there are no trainings available for interpreters or for the providers. So how to work together, how to manage an encounter together. And finally, there's not really much awareness on the patient level either, because again, there's no information produced for them, and at the clinic, there's no formal setup for how to kind of incorporate them into a conversation. It's just like, oh, the provider doesn't understand, oh, go get one of the interpreters. So there's not a well-facilitated conversation happening. So when I first wrote the proposal for our class, I wanted this to be the majority of my presentation, but given how limited our time is, it turns out this is just one slide. This is just the end. So this is what I think we should do moving forward, our suggestions for future research or things like that. So I would love to create a program in Gwangju, kind of facilitated by the Gwangju International Center, the GIC, for students recruited through the OIA at Chonnam University, and then make those student interpreters credentialed through the GIC available both for the Migrant Health Center and also to the Ministry of Health and Welfare as a database of student interpreters available for the general public and for the Migrant Health Center. That way, the students could receive volunteer credit through the GIC and their university, and also help reduce the disparity faced by migrants about interpretation services. So I have one more slide for my references, and that's the end. Okay, so these are my oh, it's the other way. Oh, how weird. These are my references, so please take a look. But I'm over time, so that's the end.